right, Suraj, I think we're ready to get started.
Great. Good morning, everyone. My name is Suraj Mishra. Thank you for attending our grand rounds today. I'm pleased to introduce our speaker, Dr. Michael Kontos. Michael Kontos is a professor at the Virginia Commonwealth University Medical Center in Richmond, Virginia, holds appointments in all of the above Department of Internal Medicine, Cardiology, Emergency Medicine, and Radiology. He received his MD degree in 1988 and completed his residency and his cardiology training, including an additional year of echocardiography at MCV. His primary research interests are in the applications of imaging and cardiac biomarkers for identifying and assessing outcomes in patients with acute coronary syndromes. A fellow of the American College of Cardiology, Dr. Kontos serves as a reviewer for Circulation, Journal of the American College of Cardiology, Annals of Emergency Medicine, American Journal of Cardiology, American Heart Journal, as well as many others. He has served as co-investigator on a number of multi-center studies investigating treatment in acute myocardial infarction and acute coronary syndrome. He speaks frequently in academic and professional venues. Dr. Kontos has contributed over 190 articles and 100 abstracts for publications in journals that include Circulation and JACC. He has been active in the American College of Cardiology and the NCDR, and currently serves as the chair of the Chest Pain MI Steering Committee. He recently completed a term as the chair of the writing committee for the recently published Consensus Decision Pathway, Evaluation and Disposition of Acute Chest Pain in the Emergency Department. He serves as both medical director of the Cardiac ICU and co-director of the Chest Pain Center, while also playing a pivotal role in the success of so many of our fellows through our training program. We're grateful for Dr. Kontos' expertise on this topic and look forward to learning from him. At the end of the lecture, we'll leave some time for questions. Please submit them via the chat function on Zoom as they arise during the talk. We're also pleased to offer both CME and MOC credit for our Grand Rounds conference series, as you can see on the slide here. So to claim credit, text the code shown at the beginning or end of the presentation to 804-625-4041. And for questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winson. With that, I'll turn it over to Dr. Kontos.
Well, thank you for that introduction, Suraj. I'll go ahead and get started here. Let's see. So today I'm going to talk about evaluation of chest pain in the emergency department and focus on two recently published documents. The first is, get these things to work. Disclosures is the chest pain guidelines that came out in 2001. These were really the first guidelines that addressed the management of chest pain, both acute chest pain and chronic chest pain. This was approved by numerous organizations, as you can see, the American Heart Association, ACC, ASE, and others. Notably, the one organization that did not approve it was the American Society of Nuclear Cardiology, which I'll discuss a little bit later. The second document is one that I had the privilege of chairing an expert group of clinicians in developing the consensus decision pathway for the evaluation and disposition of acute chest pain in the emergency department. Just as kind of a background, the differences between these are noted here. Clinical practice guidelines are really those recommendations that what you should or should not do. They're specific directives. Performance measures are a little bit stronger. They are based on things that you must do to improve care. Appropriate use criteria are those that are reasonable to do for clinicians as far as management of patients. And finally, the document that I work on in the management decisions I work on was the consensus decision pathways. This is something that the American College of Cardiology recognized a few years ago. The guidelines were getting fairly long and had a lot of details in there, and consensus decision pathways, or CDPs, that really provide a roadmap on how to implement these guidelines. And together, these define the best practices based on our current evidence for management and treatment of patients. Recommendations come out in a number of different ways. First, there are the specific recommendations, starting with class 1, which are those that are the strongest recommendations, those that you should do. In class 3 recommendations, those that either have no benefit or actually can cause harm. in between or those that are in between moderate guidelines, class 2A and class 2B, those that have less evidence behind them. Specific recommendations are also rated on the level of evidence, with level A being the strongest level of evidence, those based on multiple randomized clinical trials, and finally down to class level C, those that are just based on expert opinion by themselves. It's not necessarily that expert opinion is can be taken as a very soft recommendation. Keep in mind, the best example is that we don't have any randomized clinical trials that demonstrate that parachutes work. However, the recommendation would be a class 1C that you should use one if you're jumping out of the airplane. And it's doubtful that we will ever really have a randomized trial addressing this. So our path for our consensus decision pathway was, we primarily decided to just focus on the management of acute chest pain. It's specific. The current guidelines were fairly broad, and I think perhaps overreached somewhat, and it would have been better off if they had split it into two different documents. They focused both on the acute management of chest discomfort, but also patients that have chronic stable angina. We chose to narrow our scope and go only for emergency department management and acute chest pain management. We added some additional discussion and detail to the guidelines, focusing on initial ECG interpretation of high sensitivity troponins and how to use them in chest pain diagnostic pathways, choice of specific imaging tests, and an area that was notably left out of the guidelines, differentiation of type 1, type 2 MI, and acute and chronic myocardial injury. The first guidelines that came out that I'll talk about are the initial assessment of the patient with chest discomfort. These are fairly intuitive and obvious, and I think we all know them well. A couple differences are noted in the middle. First, it changes our teaching about how we actually talk about chest pain that we've been doing for the last 50 or 60 years. They recommend no longer describing chest pain as atypical because they felt it was not helpful in determining the cause of chest pain and could be potentially misinterpreted as being a benign cause. Rather, it should be described as either cardiac, possibly cardiac, or non-cardiac. And then obviously, as we all know, a class 1 recommendation was to perform a focus history that includes the chest pain characteristics, symptom duration, and cardiovascular risk assessment. The ECG also has strong recommendations, as one might expect, because it's still the best initial test for rapidly evaluating patients who come in with potential myocardial ischemia. As in prior guidelines for STEMI and non-STEMI, the ECG should be acquired and reviewed for diagnosis of both STEMI as well as acute ischemic changes within 10 minutes of arrival. Serial ECGs can be helpful if there's a high clinical suspicion of ACS, if patient has persistent symptoms, or their clinical condition worsens. Should also consider performing a ECG in the setting in the case the patient may have a positive biomarkers and the initial ECG was negative. Patients who do have an initial ischemic ECG should be treated according to STEMI and non-STEMI guidelines. I think this is important to point out, as many clinical trials that evaluated the use of high sensitivity troponins didn't specifically state that they excluded patients with ischemic ECGs. Areas that we've addressed that provided more detail on in our consensus consensus, our CDP, was specific other signs of acute infarction. These includes things like posterior myocardial infarction, in which you have anterior ST depression, the Winter sign, which is a prototype of ST depression with hyperacute T waves, Serboso criteria, those in which you have diagnostic ST changes in the setting of left bundle branch block. And another important criteria, I think, that's becoming more recognized, what we used to call a semi-STEMI, but now is often being called an occlusive MI or OMI. These are patients that may have borderline ST changes that are actually diagnostic of vessel occlusion. As we try to emphasize with our fellows, ST elevation by itself is, with the rationale for us using it, is that it's a fairly good diagnostic marker of what we're really trying to find, acute vessel occlusion. Patients may present with very minor ECG changes, but in concert with changes that are evident in numerous leads, identify someone with acute vessel occlusion. Other areas that we discussed were signs of ischemia, including hyperacute T waves, elevation in AVR with diffuse ST depression, and Wellen sign, which you have diffuse diffuse deep T wave introversion. There are some potential mechanisms that have come out that may help us improve our overall diagnostic utility of the ECG rather than expert interpretation. This is a paper that just came out in the last couple of months, using the techniques of machine learning to take into account numerous different details on the ECG that are not easily recognized by even the expert clinician for identifying patients who may have early vessel occlusion. This can potentially provide early clinical diagnosis, both preventing patients with missed MI, but probably more importantly, preventing the delay in someone who's ultimately diagnosed with acute vessel occlusion. You can see here, looking at this ROC curve using just the commercial ECG algorithm in the yellow at an area under the ROC curve of 0.75. Expert interpretation significantly improved this, but the ECG Smart algorithm actually improved it significantly more, identifying more patients who are either high risk or low risk. And I think this is going to provide a very useful tool in our emergency department for evaluating these patients. Next area that we focused on and expanded in our CDP was the use of troponin, and specifically we focused on high sensitivity troponins. Just as a reminder, almost all the tests we use for diagnosing MI are actually cardiac markers. They measure the direct protein concentration of that blood test and are not truly enzymes other than CK. And these are, I think, standard recommendations we are all familiar with, performing and measuring troponin as soon as possible after presentation. There are also clinical guidelines that indicate that we should be familiar with our assay, both the analytical performance, as well as the 99th percentile that defines myocardial injury, as these are all different among the different assays. CKMB and myoglobin that were provided some recommendations in prior guidelines are no longer recommended for their diagnosis of acute myocardial injury. CK still may have some utility in different areas. It's been promoted by the use of the Society of Cardiovascular Angiography for identifying myocardial injury after PCI. I think it still has usefulness for identifying reinfarction, particularly after STEMI. And because all our troponin assays are capped, if we really want to determine the size of an infarction by using cardiac markers, either CK or CKMB will be necessary for large infarctions. High sensitivity troponin is recommended for a number of different reasons. It has superior analytical characteristics that result in improved sensitivity at very low troponin values that allow us to expedite early rule-in and rule out of patients presenting to the emergency department. Where are we in the United States? This is from a study we recently published from the chest pain MI registry of about 550 hospitals. Currently, you can see a rapid upswelling in the use of high sensitivity troponins from only 3% of hospitals in 2019 up to about a third of hospitals in 2021. And I expect this has even increased further since then. I think for all of those of you that aren't currently using it, you're going to end up having to do so at some point, because the manufacturers will stop making the reagents for the older assays, and we'll have to learn how to use these at some point, which will be varied depending on your particular institution. Although high sensitivity troponins has a number of substantial improvements and over traditional assays, I think there are some caveats that you need to keep in mind when using these assays, which we discussed in our document. First, the reporting units are different. Assay cutoffs are different. You can't relate one protocol to the other with different assays. As everyone has recognized, more patients will have high sensitivity troponin elevations. Despite its improved sensitivity, it's still low in early presenters, and you do have the potential for misdiagnosis if you rely on just one biomarker, although that may be improving, which I'll show in some data in just a few slides. Unstable angina still exists despite the improved sensitivity of our biomarkers. There are a couple groups that still have issues with trying early diagnosis or any diagnosis of acute MI, including those who have chronic kidney disease and older patients. And finally, I think we need to recognize, and I'll emphasize, that troponin elevation is not synonymous with myocardial infarction. So reporting assays are different. Most of the standard assays are reported out in nanograms per millimeter. If you translate that for the Abbott high sensitivity troponin, the actual lower limited detectability is 0.001 nanograms per milliliter with a 99th percentile of 0.026. To reduce confusion, the current recommendations are to change this to nanograms per liter, so 1,000-fold higher. This gets rid of the decimal points and makes it easier to interpret. I think for those centers that are still using traditional assays, such as ours, that do get transfers from hospitals that are using high sensitivity ones, the easiest way to translate it is you can get a very rough conversion if you take that high sensitivity troponin and divide it by 1,000. So when you see someone with a troponin of 2,000, it doesn't mean they're having a massive MI, but rather that they may have, if they're using a high sensitivity troponin. And clearly, this does require us to reset what we consider a large MI. You need to know your assay. All assays have different cutoffs, both for the lower limited detectability, how low can they accurately detect a concentration of troponin, what is their 99th percentile, which they vary both by gender as well as by country, depending on who approved the assay. For example, the Roche troponin T assay has a different 99th percentile in the United States and in Europe. When instituting these assays, it's critical that you work with your laboratory so that both of you are on the same page and develop one single algorithm for identifying these patients. Luckily, in the vast majority of cases, specific algorithms for how to use these assays have been published. More patients will have increased troponin values. This affects it in both the two ways. On the left, we can see the number of patients diagnosed with type 1 MI, type 2 MI, and acute myocardial injury, whether we used normal standard troponin assays and high sensitivity troponins. All three of these increased. However, most studies have demonstrated that if you look at the proportion of patients who have elevated troponin, how many of those fall into those three categories, you actually see a decrease in the number of patients with type 1 MIs, but an increase in the number of those with type 2 MI and acute myocardial injury. So the number of patients with troponin elevations above the 99th percentile goes up, but the relative proportion of those with type 1 MI will actually decrease. The more you test, the more likely you will find there are differences in thresholds for testing troponin in different countries. This is a study that looked at patients who were assessed in the UK versus the United States. You can see that if you looked overall, proportion of patients diagnosed with type 1 MI was substantially more than those compared to the United States. Conversely, those who had acute myocardial injury were about 3 times higher in the unselected US population compared to the UK. So if you have a lower threshold for testing, you will identify more patients who have acute and chronic myocardial injury. Sensitivity is still lower in early presenters. This is from data from a large clinical observational trial that found sensitivity was suboptimal in those who presented within 3 hours of presentation. So current guidelines are that you should use serial testing if your patients present with less than 3 hours. I think this is an important consideration for how we're managing patients. Keep in mind that in most clinical trials, there was a delay in sampling troponins, primarily because patients had to be enrolled in a clinical trial. So if you take the time from them to get to the hospital, go through triage, get enrolled, that added probably at least an hour to the total amount of time of their presentation. Currently, what a number of hospitals are doing are actually moving testing to the front line to the time in triage, which can shorten that time to diagnosis, but potentially result in patients being missed because they're being sampled too early. This is even a greater consideration as people have talked about doing early troponin sampling in EMS on the way to the hospital to assess for early triage. So early presenters may have negative markers. This is true even in patients who present with STEMI, using a variety, sorry, my slides keep jumping, a variety of different cutoffs. You can see that using the 99th percentile for the Abbott assay, 15% of patients who presented with STEMI had values less than the 99th percentile. And in fact, a quarter of those on the far right who presented within 2 hours had negative troponin values. You can potentially improve the sensitivity for diagnosis in early presenters by lowering your cutoff value. If we take, for example, the Abbott assay, which uses a cutoff on, the Abbott assay on the far left in the red that uses a cutoff value of 5 for determining who patients who can be discharged home and not. You can see by lowering that to 3, we can improve the overall diagnostic early rule out rates. This red line here demonstrates a negative predictive value of 99.5%, what most people would consider an acceptable value. This means we'll miss 1 out of 200 MIs. This is looking at the proportion of patients who rule out using all of these assays. Again, about 20 to 30% of these patients will rule out just by using a very, very low cutoff, just on initial sample, even in those who present with 2 hours. However, it's important to keep in mind, there is no free lunch. There's a trade-off. Sensitivity decreases, in which you'll have less people rule out and more patients who have to undergo a regular rule out. Rule out in patients with CKD still has limitations. Most of these patients have low-grade troponin elevations, primarily related to myocardial injury, either related to underlying cardiovascular disease, such as LVH or coronary disease, or potentially as a result of acute toxicity from uremia. This results in those patients having higher baseline troponin elevations, resulting in difficulty in diagnosing patients who are eligible for rapid emergency department discharge. As you can see here on the right, patients with renal failure in 2 different trials, less than 1 in 5 were eligible for early discharge based on our current rule out protocols. This will be need to keep in mind depending on your individual patient population. Older patients are also more likely to have elevated baseline high sensitivity troponins, resulting in them being less likely to be eligible for early discharge based on the initial 0 or 1 hour sample. In fact, patients, over 50% of patients over the age of 75 have values greater than 5, which is the cutoff for the Abbott high sensitivity assay for a rapid rule out. So again, still problematic in some groups, but advantageous in our younger, lower risk patient population. So next, we did one area, a third area that we really tried to add additional detail to the guidelines that actually were not even really covered in the current chest pain guidelines, was a focus on type 2 MI in non-ACS troponin elevations or myocardial injury. Remember, if you go back to what the current recommendations are for diagnosing the MI, 3 elements are required: a detection of a rise and fall of a cardiac biomarker, preferably troponin. You have to have at least 1 value above the 99th percentile, and you have to have evidence of ischemia. This can be made up in one of 5 different ways: new significant EST changes, evidence of loss of bipolar myocardium or regional wall motion abnormalities, identification of intracoronary thrombus, either by angiography or autopsy, or finally, the presence of symptoms that are consistent with myocardial ischemia. As we all have recognized, this is particularly problematic in some patients, as because of the varied presentations of patients with ACS, one can make almost any symptom seem to be related to myocardial ischemia. This does result in overlap and some diagnostic confusion in identifying some of these patients with acute MI versus other diseases. Troponin is fairly common in a number of different disease states. Here's just a short list of these diseases that have been recognized to have potential troponin elevations. It's important to recognize that troponin is heart specific, but is not disease specific. Patients that do have elevations of troponin or detectable troponin have something wrong with the myocardium. But as I've noted numerous times, and most of us are well recognized now, This does not identify myocardial infarction. And as I stated before, these elevations can be somewhat problematic, and as resulted in some people thinking that even though we won't see nearly as many low-risk chest pain patients, the frequency of elevations will result in a permanent cardiology consultative business. One consideration is to recognize that type 1 MI is much more likely as troponin values rise. It's primarily in these very low values where we have diagnostic confusion. But once the troponin elevation increases to higher values, it's almost always a patient presenting with acute myocardial infarction related to ACS, or potentially less likely acute myocarditis. Typically, those with acute injury or type 2 MI have relatively lower values comparatively to type 1 MI, although there is significant overlap between the two. These troponin elevations, I would be remiss if I didn't state that these troponin elevations are not benign. If you look across multiple studies, those who either have type 2 MI or acute myocardial injury have a mortality that's even 2 up to 3 times that of patients with type 1 MI. They are at substantially higher risk for long-term worse outcomes, although short-term outcomes are not necessarily substantially increased. What should we do with these patients? Well, unfortunately, we still don't have any great recommendations on management. All our data based on current management is focused on the type 1 MIs. Diagnosis of coronary disease may be useful for further risk stratification. There is some observational data that would indicate this. This is data from the Sweetheart Registry from Sweden, in which they keep track of all their patients who come in with myocardial infarction, and particularly those who undergo coronary angiography. In a sub-analysis of about almost 42,000 patients separated into type 1 MIs, who made up about 90% of the population, and type 2 MIs, who made up the other 10%, they risk stratified them based on the presence or absence of coronary disease in those who underwent angiography. Importantly, what you see is that those who had type 2 MIs, I've noted before, that did have coronary disease, had a substantially higher mortality than those in the red, those with type 1 MIs who had underlying coronary disease. Importantly, though, in the absence of coronary disease, either type 1 or type 2 MI, mortality was very low. And I think this indicates that at least in those who don't have coronary disease, they're at substantially lower risk. Should we do routine risk stratification of these patients? Well, it's unclear. In our current consensus decision pathway, we recommended that these patients be treated like secondary risk factor, as patients with known coronary disease with aggressive risk factor modification and consideration of evaluation of ischemia. I think this diagnostic and treatment strategy works fairly well for most of our patients. As obviously assess them for evidence of ischemia. Almost all patients should get an echo because this helps us to define both ejection fraction as well as the potential for underlying myocardial abnormalities. In many patients, particularly if there's an indication for ischemia, stress evaluation would be useful. With cath in some patient, the minority of patients in whom we consider a very high risk. Again, patients should be treated aggressively for secondary risk factor modification, with all patients receiving statin, probably everyone receiving aspirin, with other medications depending on the underlying evaluation. The next area we discussed was the use of rapid chest pain diagnostic pathways for evaluating patients who come in through the emergency department. High sensitivity troponin cannot be used alone. It needs to be used in combination with a standardized diagnostic pathway for these patients. Recommendations that came out of the guidelines were the patients should be classified into 3 groups: low, intermediate, and high risk, to help facilitate their disposition. There were a number of different serial time intervals, 1 to 3 hours for high sensitivity troponins, as there are numerous algorithms for using these. This needs to be extended for those using conventional assays because of their lower sensitivity. And then in those patients who do undergo observation, repeat sampling at 3 to 6 hours after that. As a 2A indication, a single troponin, high sensitivity troponin below the lower limit of detectability in a normal ECG can be used to exclude myocardial injury if they present more than 3 hours after presentation. And that's what most of these clinical pathways do, is a variation on these protocol, which I'll show here. This is a 0-1 hour protocol. Patients undergo troponin sampling at 0 and 1 hour. Others use a 0 and 2 hour protocol, which may be more logistically easier to do in the emergency department rather than trying to get your troponins done within 1 hour. Depending on what protocol you use, you really need to have an aggressive QA program to make sure that markers are being sent at the appropriate times, because many of these protocols are based on specific time intervals for troponin sampling. This looks a little bit confusing for you, but I'll kind of walk you through it. On the left, we have low risk patients, and you can fall into this group in 2 different ways. First, you have an initial troponin that's very low, depending on your assay, as we discussed before. If your 0 hour is very low, less than that very low cutoff, and you present more than 3 hours of presentation, you can go home right away. Second, you're eligible for rapid discharge if on serial sampling, there's very little change between your 0 and 1 hour, or in other protocols, your 0 and 2 hour protocols. At the other end, patients who have very high troponins or have a very significant change between 2 samples fall into the higher risk group. These are not classified as low risk is rule out, but high risk, the high values are not considered rule in, but rather abnormal troponin values, with the recognition that at least a quarter of these patients will ultimately not be diagnosed with MI. What cutoffs you use for determining whether they have a significant change in your absolute values is going to depend on the different assay that you use. And these are outlined before, and we have this provided in our consensus decision pathway to facilitate management of these patients. And again, at least in the US, although we're fairly far behind Europe in instituting these assays, it does have the advantage that we no longer really have to reinvent the wheel to try to determine what is optimal for these individual, what the optimal protocol is for individual assays. What can be gained by using these fast algorithms? This is a compilation of about 8 studies, primarily performed in Europe, that demonstrated that just using your 0 and 1 or 0-2 troponins, up to a half of patients can be discharged very quickly within that time period, with about a quarter of patients falling into the observation group, and about 1 in 6 falling into the rule-in, or again, the abnormal troponin group. So it provides a fairly good differentiation of individual patients. How does this work in the US? Well, actually quite similar. If you look at a study using a high sensitivity assay in the United States of a little bit over 2,100 patients with suspected ACS, patients were again grouped into 1 of 3 different categories: rule out on the left in the green, rule in or abnormal troponin on the right, and an observation group that fell in the middle, those who did not either have very low values or had mildly elevated values with either a minor change in the overall troponin values. In this group, consistent with other ones, about half of the patients fell into this low risk rule out group, which the diagnostic rate of MI was only 0.3%. Again, about 1 in 6 fell into this high risk group, and about 69% of patients were ultimately diagnosed with myocardial infarction. The observation group, which is going to be potentially problematic, which I'll discuss in a few minutes, was about a third of patients, and the rule-in rate was here of about 5.5%. Again, an important consideration that these patients are higher risk than what we typically see in our current clinical practice. What about risk scores? Well, if you look across most hospitals, including ours, they use some variation of initial risk score. We use the heart score to help identify patients. It turns out that these may not be all that useful, at least using high sensitivity troponin. This is a study that looked at a variety of different risk scores compared to troponin alone on the left versus combining it with the TIMI risk score, GRACE, EDAX, another emergency department risk score, and the heart score. What they found is that just using troponin alone had a negative predictive value of 99.7%, which was really unchanged by adding any of these risk scores, What they did find was that the proportion of patients eligible for early discharge actually dropped off substantially in these groups. I think there's an important consideration, though. Part of it is going to be dependent on how you define MACE. Is it defined as death and MI, or do you include other endpoints such as revascularization, subsequent ACS admission, or other acute cardiac events? By using a broader definition of adverse events, some trials have found that the negative predictive value of troponin alone may be lower than what we typically see, and adding risk scores can be helpful to these individual populations. It also may be dependent on what your patient population is. Do you have a higher risk group, more older patients who potentially are at higher risk for subsequent events? What we decided to do in our guidelines was to compromise and allow clinicians to discharge patients early if they were low risk, but take into account the clinical assessment if they would like to, using a risk score, and that those patients who were at very low risk, even those patients who were low risk based on troponin alone, but higher risk based on their risk score, would be potentially eligible for non-invasive outpatient testing and at least more rapid follow-up. So I think we need to keep that in mind, that the clinician is still important to keep in the loop as far as how we manage these patients, that it's not a troponin-centric assay alone. Clinical considerations needs to be taken into account. How to do so may actually be adapted by using machine learning that takes into account numerous different clinical variables that allow us to identify higher risk patients in a more rapid fashion rather than just using simple clinical diagnostic algorithms such as a hard score. One is that's just been developed, that was just recently published, that was not available when we came out with our guidelines, is this decision support aid that has the advantage of taking into account numerous variables rather than using just simple cutoffs or fixed troponin values. You're able to input both clinical variables that may vary on the individual patient, such as time from symptom onset, to clinical variables that include heart rate, blood pressure, and other risk factors. And finally, laboratory tests that may help us to identify higher risk patients, including the time of presentation. This is actually now being studied in a randomized clinical trial in the UK to see if this helps to facilitate early, more rapid discharge. Where these decision pathways may be useful is it allows, at least in observational retrospective data, allows to identify more patients who are eligible for discharge, decreasing that intermediate group of patients who fall into the observation group. So I think this mechanism is highly promising, and we may find this to be in more broader use in the near future. As I mentioned before, we don't see nearly as many patients with unstable angina as before. In fact, in this review from about 10 years ago, Eugene Brownwald and David Morrow, a biomarker expert, said that perhaps it's time for a requiem for unstable angina. However, it's still present if you look across clinical trials. Anywhere from as low as about 3% up to about 15% of patients still may present with unstable angina. I think these are primarily patients that are presenting with known coronary disease, that are having recurrent symptoms that have accelerated, perhaps not enough to actually result in myocardial infarction, but are worrisome enough that they end up undergoing revascularization. So I think that's important to keep in mind, that you can't rely on troponin alone for identifying a patient who's eligible to go home. Well, the final group is what happens when patients fall into this observational group, in either the rule out group or the abnormal group, in which they have a potential high rate for coronary angiography. What do we do with these patients? Guideline recommendations came out with these as far as specific recommendations for imaging. They gave a class 1A indication for use of CTA to exclude coronary disease, whereas stress testing, although also a class 1 recommendation, dropped to a 1B recommendation, with choices of different diagnostic tests depending on whether other evaluation that patients had, either prior CTA stress tests that were non-diagnostic or inconclusive, with those receiving 2A recommendations. This is, I think, primarily the reason that the American Society of Nuclear Cardiology had some trouble with the guidelines, and was primarily related to the oversized role given to CT, and particularly with the use of FFR. They recognize that only currently one company provides the utility of FFR. There's very limited availability for this. In fact, if you want to use it, it's a send out test and may take a day or two to get your results back. The utility and availability of CTA is still somewhat limited, and there can be inconsistent insurance coverage. Their recommendation is, rather than giving a 1A to CT and a 1B, a lower recommendation to imaging, that the decisions about test ordering is in fact fairly nuanced, and it really needs to take into account both physician and technical local expertise, test availability, quality of your equipment, and probably most importantly, patient preference. We attempted to incorporate these in our diagnostic testing algorithm for intermediate risk patients, in which we considered first, for initial evaluation, a rapid transthoracic limited wall motion to assess for patients who may be higher risk that have unsuspected severe ACS. And then the next, probably critical, and that's not always done, review prior imaging cardiac tests to determine whether or not the patient should be considered high risk or not, and take into account the other imaging. Things that would favor CT over or would it favor anatomic imaging with CT over functional imaging with stress testing, including the factors on the left, particularly those that don't have any known coronary disease or don't have severe coronary calcification, and those that can't exercise. Whereas factors that favor stress testing would be those who have known coronary disease, severe coronary calcification, contraindications to CT, and lack of timely access. I think one area that I think was not recognized in the guidelines, and we did have some discussion with in our consensus decision pathways, is that these observation patients are not low risk. It's not like what we're currently seeing in our areas. They have a substantially higher rate of prior myocardial infarction, which may be anywhere from a quarter to more than a third of patients. And across multiple studies, about half of them have had prior revascularization. So that would indicate that many of these patients would not be eligible for CTA for further evaluation. In fact, if you look at those patients who have low-grade troponin elevations, those that typically are going to fall into this observation area, a substantial number of those are going to have significant disease. And whether CTA is going to be useful to identify the quarter of patients who don't have significant disease versus pursuing coronary angiography in a timely fashion is currently unclear. You also need to keep into account for those who may have disease, FFR may not be immediately available. And then finally, the extra cardiac findings that you see on CT can be problematic for overall follow-up. There's actually limited data that demonstrates what how many observation patients are eligible for CT. This is the only one I could find, and it's quite dated from 2016. And they found that only about 21% of those patients who fell in the OBS group were actually eligible for CT, either based on factors such as known coronary disease, having unfavorable body habitus, evidence of arrhythmias or renal failure, and other contraindications. So again, I think stress imaging is not going to go away, and in fact may have increased utility in these patients long term. I think one concern, let's finish out, is what is going to be the impact of implementing high sensitivity troponins in the ED? I think we all fear we're going to be overwhelmed with troponin elevations. Well, at least early data indicates that this has not been seen in places that have implemented it. If you look at the Mass General Brigham system on the left, no significant increase in the use of echo, and in fact, a decrease in the use of stress testing and CTA. Similar findings in the Mayo Community cohort, in which they found lower rates of stress tests than angiography. And in a broader registry of a little over 600 hospitals from chest pain MI registry, looking at low-risk patients, again, no significant increase in the role of additional diagnostic testing. So I think at least if you're implementing diagnostic protocols appropriately, this may provide some reassurance that we won't have the overwhelming, that won't overwhelm our system. So for those that have not yet implemented a successful transition or are in the process of doing it, I think these recommendations provide a useful guideline. You clearly need collaboration, preparation, and education are essential for the transition. It requires collaboration among different groups, not just emergency medicine and cardiology, but clearly needs to include input from laboratory as well as hospital medicine, given the increasing role that they have in management of these patients, as well as any other stakeholders are involved in the management of care of patients with potential myocardial infarction. It's a checklist, which I won't go through in great details, but it does provide recommendations on how to implement this successful transition. This came out a few years ago as a clinical statement from the ACC, and provides a wealth of information, including department checklists that can be used, as well as a focus on specific guidelines to it. So to conclude, evaluation chest pain it still is challenging, contributing to ED overcrowding, resource use inefficiency, and diagnostic delays. Despite newer diagnostic tests we have, the ECG remains the best diagnostic test for identifying patients because it's rapid, inexpensive, and provides critical diagnostic and prognostic information. Any hospital that's implementing high sensitivity assays, you really need to know your assay. What are the cutoff values? What are the 99th percentile? What are the analytical issues that you may have with it? Assays cannot be used alone, but have to be used in conjunction with rapid chest pain decision pathways to facilitate rule out, disposition, and discharge of low-risk patients. One advantage of these protocols is that for those patients who fall in the low-risk group, non-invasive test is no longer required and is in fact not recommended because of the limited utility for adding additional diagnostic information. For those in whom non-invasive testing is indicated, the choice of test needs to take into account patient factors, prior test results, test availability, the test reporting timeliness, and importantly, institutional expertise. As I've stated before, we all recognize these assays will increase the number of patients with both acute non-ischemic and chronic injury. Collect classification is going to be important for implementing appropriate evaluation and treatment. And finally, these rapid pathways and use of troponins will substantially change ED workflow with more patients discharged directly from the emergency department. Therefore, protocols that ensure adequate follow-up will be required. In addition, these OBS group patients that fall in the observation group are going to be at significantly higher risk and potentially not going to be eligible for a rapid discharge within 24 hours, as we typically see. So I will stop there and be glad to take any questions that might come up.
Thank you, Dr. Kontos, for that excellent overview of this topic that's so relevant to our field. We have a few minutes for questions. Please certainly type them into the chat. I'll start by asking, is our institution here at VCU ever going to move towards one of the newer assays like the high sensitivity troponin?
Well, as I mentioned earlier, this is going to happen every place because you won't have a choice, as the reagents that are used for the traditional assays will go away. However, the timing is complicated and more complicated than I thought. One of the issues we have, particularly at a hospital system like ours, it's not as simple as just popping out a troponin assay and popping a new one. All troponin assays are part of a very complicated analyzer that may perform anywhere from 50 to over 100 different diagnostic tests. So in fact, the choice of tests and what assay you get is really not based on your particular preference, but based on the capability of that analyzer to be able to perform all those other diagnostic tests. So that's one issue that you run into, that you have to change the analyzer. And then second, if you look at our institution like ours, where we have 3 different hospitals, you can't really have 3 different troponin assays in different areas. So for us to change would require getting new analyzers, one in the main lab, one in the ER, one from New Kent, and then analyzers at both CMH and at Tappahannock. one of the issues is the Abbott assay that we currently use, their platform that's currently approved for use is a little bit too big for some of those labs. It would require us to change out over 7 different analyzers. So I think it's going to be probably the 2 to 3, and then that would probably be the cost for that is going to be over, I think, 7 figures. So it may be a number of years before we change. It will happen, but probably not as fast as I thought it would be within 6 to 12 months after the new guidelines. But one thing we will have is at least an early warning and have a number of months to prepare for this once we do transition.
Great. We have a question in the chat from Dr. Huizar. Is there a decrease in unstable angina because they're not diagnosed instead with an MI, given the kind of change to the high sensitivity markers?
Yeah, that's actually correct. What's happening before we were using relatively insensitive markers. And in fact, a number of those patients that we called unstable angina, using a more sensitive assay, now we're picking up myocardial necrosis. So we've actually shifted the number of patients with acute, increased the number of patients diagnosed with MI as the number of patients with unstable angina has decreased. It actually has an interesting effect. We looked at this a few years ago. And if you take patients with unstable angina, they actually have a lower mortality than the acute MI patients. Now, if you shift some of those into the acute MI population, you actually result in a decreased mortality in your MI population. Although those patients are much higher risk than no troponin elevation, those patients with those minor elevations are at significantly lower risk than, say, a patient with STEMI.
We have a question from Jeff Kolominsky. Are there any studies that have randomized ED risk scores to chest pain patients to see if their use can translate into patient benefit, seeing as they did not have any better positive predictive values when added to the high sensitivity assay?
I think as far as randomizing, no clinical trial, as far as I'm aware, have done this. Usually they've retrospectively applied the criteria for those risk scores to see what's happened. Like I said, there are some studies that have found that in the absence of risk scores, those patients are at higher risk. Again, it may be differences in patient population, as well as the choice of individual endpoints. There are 2 clinical trials I think they're going to be coming up in the next couple of years. They're going to be using these techniques such as machine learning to randomize patients to either no risk score versus using one of these to see if it can help improve diagnostic efficiency. I think what you'll see is that the missed MI rate's not going to really change. It's very hard to improve over a 99.8% negative predictive value, but what potentially will do is shift more people into that early rapid rule out. They're eligible to go home and decrease that observation group. And I think that's where the focus is primarily going to be on using these protocols.
Okay. David Gajoka is asking, per the high sensitivity troponin, why would different labs have different cutoff levels per your slides? They're planned to have a uniform level.
That's an interesting question. Part of it has to do with how these assays are approved. The FDA, it depends on what 99th percentile you decide to do. In general, most assays have a standard 99th percentile across populations. What we found with the high sensitivity assays, though, the 99th percentile is actually different for males versus females. So you need to have different cutoff values. For labs that aren't keeping up with the data, you may just pull out the package insert and use it, as opposed to using these different values. The choice of what your lower limited cutoff value is also important. A lab may use the 99th percentile, which is actually quite high when you look at how good these assays are as far as identifying patients with myocardial necrosis. For example, I'm trying to, let's see, I'm trying to get, some reason I can't get back. So for example, often these assays may have a 99th percentile that are around 20 nanograms per liter, whereas the lower limit of detectability for these may be closer to 2, 3, or 4. So they may not report out lower values than that, or how you what you call abnormal may be varied depending on the assay. That's why some have argued that the 99th percentile should just go away, because many of these diagnostic algorithms don't actually use the 99th percentile. They're using different cutoff values. So knowing what the characteristics of your assay are important. The FDA actually there's also differences in approval for the different lab tests in Europe versus US. For example, in Europe, you can go down to the lower limit of detectability, where in the US, the cutoff value is actually higher than that because the coefficient of variation is more variable the lower you go.
Mhm. And Dr. Joven here is asking, do you think that the same thing will happen with high sensitivity troponin that happened with INR and ISI that ultimately led to uniform values?
I don't think you'll see uniform values because the assays are so markedly different and they all detect different parts of the troponin molecule. So you're always going to see variations in numbers. That's again why you can't translate one troponin assay into another.
And then Rahul here is asking, can we use high sensitivity troponin for long-term prognosis after an MI, not just the diagnosis itself?
That's probably one of the more interesting areas of troponin, is that it's not just a marker of acute injury, but chronic injury. And there's now substantial evidence that you can identify patients who are at higher risk for adverse events just based on using these low values that are detectable, but still below the 99th percentile. These come up in a number of different areas. And that's why you particularly will see patients with older patients have higher values because they do have measurable troponin in their bloodstream. It's interesting if you look at it. The Abbott assay is actually improved. It has an indication for long-term prognostic value in individual patients. There are some studies that have actually looked at trajectory, that patients who have a detectable troponin that goes down in the future to have a better outcome than those who have increasing troponins that go up if you serially assess them over time. And I've often said that one thought may be that in the future, what you're going to do when you go see your primary care physician, not only will you get your cholesterol checked, you'll get your troponin checked. And if your troponin is completely normal, there's no reason for you to even get additional diagnostic testing, such as an echo. There are some data that indicates that if you add troponin values into other diagnostic tests, and for example, a low-risk hypertensive patient, you can further differentiate those into higher and low-risk groups, perhaps identifying those who need more aggressive treatment for their blood pressure. Similar data has been reported out using coronary calcium scores as well. So I think you'll see a much broader use of these assays in the more chronic disease population, as Dr. DeLamos talked about when he was here last year.
That'll certainly keep us in business. If the troponin level, this is Mohammed Peer, one of our new interventional fellows. He's asking if the troponin level at 1 and 3 hours is both lower than the 99th percentile, but uptrending. Should we wait for another 3 hours to see if it increases above that 99th percentile?
Again, it would really depend on the assay and the values. Those patients likely would fall into that observation group of patients. And in that situation, they would get additional sampling 3 hours later.
Okay. And then I just had another question. Are there any newer assays like inflammatory biomarkers or anything that's more specific maybe to the plaque rupture event that's being worked on for the future?
There are numerous different biomarkers that I think have been evaluated and undergoing utility for identifying patients, both at short-term risk as well as long-term risk. At least for identifying acute MI patients, nothing has even come close to surpassing troponin. For identifying those for long-term risk, there are a variety of different markers. Part of it is the issues are, first, how easy is it to measure? Some of these tests can be quite complicated, particularly any blood tests that say look at platelet reactivity or thrombosis. And then second, how much extra utility does it add on to additional testing, or does it help further risk stratify the individual patient that you're already treating quite aggressively? And I'm not aware of any data that's found anything that's currently being used, although I think most people think there may be some promising assays, but I'll be surprised if anything comes out in the near future.
Okay, and the last question here, what's the significance of troponin in vasospastic angina presentation for chest pain in the ER?
It's an unclear issue, and I've not looked at that recently. One of the areas is that there's always been a question whether does troponin always identify myocardial infarction, or can it go up with ischemia? And at least it does appear that it is released in acute ischemic episodes. So it may not be purely specific for infarction, but more specific for injury. For example, you can see elevations in people who do extreme exercise, such as marathons, bike riding, and other things. Probably the more interesting study is in which they performed rapid pacing in the cath lab and measured coronary sinus lactate concentrations and troponin values, and found that they were associated with it. So it does appear that it can go up with ischemia alone. This may relate to either release from the cytosolic pool or relate to release from apoptosis. For patients that present with coronary vasospasm, I would think you would need to have at least a short-term occlusion to have some sort of elevations in those patients. Again, one of the things that's going to be different in that patient population versus the ACS is that ACS populations, even though the artery may be open, you've got suboptimal coronary flow with intermittent vasoconstriction and crappy blood flow that may result in further increase in troponin, but also a delay release, where with vasospasm, you're going from an acute occlusion to complete reperfusion. In fact, maybe hyperreperfusion because the artery's open, and you'll get a much more rapid washout of troponin in that. So you may see some variation in your troponin curve in that patient population.
Makes sense. Well, I think that's it for us today. Thank you so much, Dr. Kontos, again, for your time, and for everyone for joining us this morning.
Thank you.
All right. Have a good day, everyone.